Everyone, and welcome to tonight's Hot Topic in Healthcare event, Expect the Unexpected, What Nobody Tells You About Postpartum. My name is Carrie Ann, and I'm the Associate Director of Graduate Admissions here at Bay Path University, and we're so glad to have you this evening for what promises to be an insightful and thought-provoking discussion. Before we dive in, just a housekeeping note, this session is being recorded, so if you need to step away or want to revisit any part of the discussion later, we'll be sharing the recording with all registrants after the event. Also, if you have any questions during the session, please type them into the empty questions box, and we'll address as many as we can during the Q&A portion at the end. Tonight's conversation will shine a much needed light on a topic that is often overlooked, the realities of a postpartum period and what birthing people and their partners truly need in these days, weeks, or even months after childbirth. Let's see. So through our panel discussion, we'll explore the immediate and extended postpartum needs for both vaginal and cesarean births, the powerful role of postpartum care professionals like doulas, lactation consultants, and pelvic floor therapists, and how we can better integrate these professionals into the healthcare system to deliver a more holistic, family-centered approach. We'll also look at strategies for improving postpartum practices and policies in both hospitals and clinical settings, with a focus on building more resilient, collaborative systems of care. So I will let everyone speaking this evening introduce themselves in the coming slide, but thank you for all being here, and thank you for joining us tonight and being part of this vital dialogue. With that, we can get started.
Thank you so much, Carrie Ann. We are so excited to be here today, and welcome everyone. We're gonna go ahead and get started. There we go, my slide is moving now. So today we're really excited. We're coming in with a panel for you all. So we wanted to do a quick overview of the perinatal system landscape. We are going to focus pretty exclusively on Massachusetts tonight because that's where we are all from. And we'll go do introductions in just a moment. We'll have a facilitated discussion and then open it up to the group for some Q&A. So feel free to pop your questions into the chat as we're going along here. And in fact, we'd love to see who's here with us on the call tonight. So if you want to chat your name in, your pronouns, one thing that you would like to learn from tonight's discussion, and we want to make sure we come back to those at the end of the conversation tonight to hear what those things were and see if we can answer those questions. And again, use the chat throughout and we will pull those questions in at the end. All right, I'm going to go ahead and move us along so we can do our intros. My name is Avery Margonaut. I am a doula. I also have been working in public health since, oh gosh, I don't even know. I won't give names now, but for a while across maternal and child health sectors and now in elder care. Really excited here to be here tonight. And I will pass it to my colleague Amal to introduce herself.
Thanks, Avery. So I guess I'm the intruder here because I don't actually live in Massachusetts anymore. But my name is Amal Hashush. I know that my little box says Amal Cooney. That's my married name, but I do go by Hashush. I'm a new mom. My little baby is almost 5 months old, so this is a real topic for me. And I currently work in early childhood systems, really, but my love and passion and joy is maternal and child health. So I am fresh off of birth this morning, so really thinking about the postpartum period and excited to be with you all today. I have the pleasure of kind of passing it over to Jane and Danielle just for a second before we get started to introduce themselves quickly. So I'll go ahead and pass it to you all.
Oh my God, I can go first. I'm Jane Gajewicz. I am the owner of Boston Area Doulas, which is a doula agency with about 40 doulas. So we provide birth support or pregnancy support, birth support, and postpartum support to families all over the Boston area. I am originally a scientist by training and did a major career switch after having my son and realizing how difficult the postpartum period is. And I wanted to do something that could kind of improve the perinatal journey for other moms. So thanks for having us. I'm really excited to talk about this important topic.
I'm Danielle Power. I'm a doctor of physical therapy. I have been
practicing in the greater Boston area in a variety of settings. I started working with pelvic health patients while I was in graduate school and fell in love with it, and have really evolved my practice to work with pregnant and postpartum patients, and combining sports medicine into my practice. I own my own solo practice. It's a cash-based practice called Power Physical Therapy, and I am currently expecting my first baby. My wife is carrying, so she's due in January, and we're really excited.
So, Meg, congratulations.
So exciting, so many babies. Thank you so much. We're so happy to have, Avery and I are so happy to have Danielle and Jane with us tonight to be able to share their perspectives from across the different pieces of the system, which we hope to be able to touch on. So I've got the difficult job of trying to zoom out really quickly and just give a brief overview of really what maternal health looks like in the US right now. We really want to be able to focus the conversation on the discussion with Danielle and Jane. So we'll kind of try to go through this quickly, but by all means, if you have questions, please leverage that chat box function, and we'll make sure that you all have the resources that we've linked here as well afterwards. So first off, I'm sure this is not a secret or not news to anyone, but we spend a lot of money in the United States on healthcare. And despite that, we do not have the best outcomes. And in fact, they're far worse than most countries that are sort of at our economic level. So a couple of things that Avery and I really wanted to point out for you all is that one thing that's a big problem is that there are a lot of places where it's hard to find care, and it's hard to find prenatal care and postpartum care, and it's actually getting worse. So when we look at the statistics across the globe, we have far fewer OBs and midwives than other countries. And so just in general, and just looking at that one piece of the system, we have far fewer providers able to actually provide care to those who really need it. So despite saying, hey, make sure you go to your prenatals and get the, your appointments after giving birth, we don't always have something that's easy for someone to be able to go and find that. So wanted to point that out for you all. The other thing that's really important, and we can't really do this the justice that it deserves, but our disparities are pretty frightening in this country. And according to some recent data in 2023, we've really unfortunately widened those disparities. It saddens me every time we have to have a conversation about this, but the reality is we are not protecting mothers, and specifically we are not protecting mothers of color, Black mothers. So there has been some improvements in outcomes, specifically for other racial and ethnic groups. So that's important to really note. So keeping in mind that while we are making some improvements, we really need to make sure we're focusing on those populations that are being least served, so that we can think about how a rising tide lifts all boats, and really focusing on who needs the most support at this time. Recently, we've had a lot going on in our federal government. And right now, I'm sad to report that one of our biggest programs that supports maternity care in the US is really under attack. So Medicaid, we don't really know what the verdict will be at this point. I haven't checked the news today, but I think we are still in the midst of a shutdown and don't have clarity on really what the budget proposals will bring for us in the future. But it's important to understand that Medicaid is really a cost sharing program between the federal government and states. And so if money gets taken away at the federal level, states will have very difficult choices to make as they have to redo all of their budgets. So you should really be keeping a close eye on that, as that's really going to, it's going to impact a lot of stuff. And Medicare, cuts to Medicare as well, which is the program that, supports traditionally older folks. Any impacts to that program is going to crowd out funding that hospitals and healthcare systems use to support important programs and sort of subsidize other care. So just because it's happening to not Medicaid, doesn't mean it's not going to impact some of the things that we're talking about today. So wanted to kind of shine a light on that. Lastly, what we're really wanting to focus on today is that postpartum care. And so it's not only about the care that you get prenatally, the care that you get when you're pregnant, but there's a lot of things, a lot of important things that happen after the fact. So we're going to kind of zoom in there. And with that, I think we can go to the next slide and give a little bit of a question. I think this was surprising data as Avery and I sort of shined our magnifying glass on it. And I don't know if we can use chat, but maybe we can try to do that, and we'll give about a minute or so to say, what do you think? So the question here for everyone to sort of answer in the chat, if you have a second, is in what stage do you think the highest percentage of maternal deaths occur? And as you think about that, I do want to point out that a lot of the data that we look at in this topic is related to maternal mortality. And I just want everybody to remember that that's really kind of a tip of the iceberg situation. So just because we have, X number of horrible death outcomes, that doesn't mean that we're looking at the whole problem. There's a whole slew of other outcomes that are happening underneath the surface. So we are focusing in this question on maternal deaths and wanting you to think about where that typically happens, but just remember that there's a lot of other stuff going on as well. All right, so it looks like the answer's on the bottom of the slide. I guess I didn't even realize that. Whoopsie. So you didn't have to do too much thinking there. It is option D, late postpartum. I think this was surprising to me. I think Avery, you and I both thought the same thing, that it was kind of in that option C, like early postpartum. But that in fact is not true. And I think Avery has a little slide she's going to show you, so I'm going to pass it back to her.
Yeah, sorry about the answer being on the slide, but hopefully it made us think a little bit. We often focus on, and I think Hollywood reinforces the idea that birth is really the moment in time where we might experience the highest mortality rates, morbidity rates. But it's actually that percentage, that shift you see on this graph towards the postpartum period, where we're seeing 12% 1 to 6 days postpartum, 23% 7 to 42 days, and then up to a year, 30% of maternal deaths happening in that period. So when you add all those together, it's way more significant than the prenatal stage and the birth stage. And this is interesting and a little bit ironic, because the inverse is what we're paying attention to often in that prenatal and birth phase, in terms of where the support and surround systems are for birthing people, for pregnant people, versus the postpartum period, where we actually see the drop off in that support happening. Oops, clicking on a different set of slides. So we do want to zoom in quickly on Massachusetts, and then kind of zoom into the folks who are here on this panel today to kind of talk about all these things. Often in Massachusetts, I think we have the luxury of thinking, well, like we're doing pretty good. Like we have these social support systems. And while we do perform better than many other states, there still are significant gaps that we need to pay attention to, specifically around social supports, policies, and unique structures that are in place that reduce access across the board. So looking first at kind of what are those poor drivers of outcomes, there are many socioeconomic barriers, like inconsistent prenatal care, which Amal was speaking to, those gaps in mental health supports across the board, and also risk reduction resources that are available to folks who are impacted by substance use. We also know that we can't ignore structural inequities, systems of racism, sexism, transphobia. All of these things create further barriers to care and make outcomes worse for those already at-risk populations. So those are things we want to kind of like add a lens to when we're thinking about Massachusetts specifically. How that looks in terms of outcomes in our state, we know that about 11% of pregnant people in Massachusetts are not receiving that adequate prenatal care. And that's really defined by getting half of the recommended visits that you should be getting in your prenatal term. We also know our preterm birth rate is about 9.1% for Black birthing people, which is 1.3 times the rate of others, of their peers. So we're seeing those racial disparities. We're seeing the disparities in being able to access prenatal care. And how that all kind of compounds into the birth room, the experience when you're actually in labor, is we see a really high C-section rate in our state. So about 27% of births, first-time parents who come into their pregnancy at low risk are still ending up with a C-section. And we do want to be explicit that there are absolutely scenarios where C-sections are life-saving and they can be very necessary. But there's also a lot of scenarios where a cascade of interventions kind of takes place and non-medically reasoned inductions or other factors increase the likelihood of getting those C-sections, which are significant abdominal surgeries. And again, we don't have the supports in place in that postpartum period to really support that healing and the time that it takes for recovery. Kind of wrap up this slide, just some other context pieces to add. As Amal was talking about OBs and midwifery access, in our state, particularly while midwives are allowed to practice independently, there isn't paid parity. And so there's no licensure pathway for certified midwives to be able to practice on their own. There's a lot of bills going around right now, so please support those if you're interested. But it is something that has been a long time advocacy effort in our state. And we also know simultaneously that there's a lot of closures of birth centers. Options where people can give birth are becoming more and more limited. So we see independent birth centers closing. We see difficulty in opening new independent birth centers, which really restricts where people can choose to give birth for themselves. And then finally, when we look at what is our policy coverage in that postpartum phase, we know that Medicaid is expanded, and so it does cover up to 1 year postpartum, which is critical. But we do want to see more of how we can get more and more families supported in that postpartum period. So all this to say, we've tried to summarize a pretty huge context. And oh, my slide, is it coming? Here it comes. There it goes. All right, we've tried to summarize a pretty huge context in a very short window. But what we hope you can take away from this is that at the center of the system is the individual person who's entering their pregnancy, their postpartum period, with varying states of supports and sources of privilege and ways of kind of interacting with the systems that we have. And within all those factors, there are levels where the best case scenario, all those pieces start to work together. And worst case scenario, we don't see those pieces work together. People fall through the gaps. They're not able to get the care that they need or the support that would help them thrive. So that's really where we're going to root our conversation today, and thinking about the transitions between care, the geography of what's available, whether you live somewhere that's rural or more urban, how these different workforces interact together or don't, and really how we can better support families in that postpartum period. So without further ado, we're going to bring our panelists into this conversation with us. We've already done our introduction, so I'm going to hand it over quickly to Danielle to speak from her lens of really what are some of the similarities or differences between how other medical conditions are treated and how pregnancy might be treated in context.
Yeah, so we're gonna use the ACL injury as an analogy because we all probably are somewhat familiar with an ACL injury. So an ACL is a ligament that provides stability in the knee, and when the ACL is torn, it's a major orthopedic trauma. It's a very long and involved rehab process, and the tear affects the muscles, nerves, and connective tissue that surround the knee. So there's a significant amount of pain, there's swelling, atrophy of the muscle, and this leads to significant functional limitations. So knowing that, what kind of treatment would you expect to receive if you tore your ACL? You would expect imaging with a clear diagnosis. You'd have a consult with a specialist. You'd get into physical therapy very quickly. And you'd have lots of education provided about your injury and your rehab process. You'd have a very specific rehab protocol, multiple follow-up appointments with the specialist, with your surgeon that referred you to rehab. You have very high expectations that your rehab provider is going to spend a lot of time with you to help you get back to, or as close as you can get back to your prior level of function. And then what do you expect for your recovery? This is a 9-month-long to a year-long rehab process. And if you're an athlete, it can be up to 2 years for full capacity for your athletic goals. So you're going to expect that along that
that path, you're going to have to make adjustments at work with your community involvement. Your athletic goals are pushed aside. You're going to expect that there's going to be some setbacks, some plateaus in your recovery, but you have a medical team and rehab professionals that are going to support you throughout that process, and that you're going to have fear and anxiety because you don't really know what your prognosis is going to be, but there's going to be someone to help you give clarity along that journey. And then you also expect that your teammates, your coworkers, your family members are going to adjust their expectations of your productivity, your everyday activities of daily living. And you probably would hope that the people closest to you would help step up a little bit and help you with daily tasks that you're having a hard time doing during that recovery process. So now let's juxtapose that with the pregnancy and postpartum period. With postpartum individuals, what might you expect? You might expect that after the baby's delivered, 6 weeks later, you go to your medical doctor visit and you're cleared for normal activity and you're doing the bounce back, which that term actually makes me cringe, but you're bouncing back 6 weeks later. Often not discussed is that during pregnancy, the muscles are adapting to a pregnant body, which means many major muscle groups are strained. There's altered muscle firing patterns, there's postural changes, hormonal changes, bowel and bladder changes, and then there's the actual delivery. There's so much variation with what's going to occur during delivery, but you're typically going to see some further muscle strain, potentially muscle and skin tearing, scar tissue formation, which is painful and dysfunctional, hormonal shifts, potentially nerve stretch injuries, bone fractures, and then, as Avery had mentioned, if there's a cesarean section, that's a major abdominal surgery that cuts through 7 layers of tissue that all heal at different rates. So back to expectations, knowing all this, you wouldn't expect someone to sustain an ACL injury and then have this one-time 6-week appointment where you're cleared to return to a high-level sport. However, that can be that's pretty standard for the postpartum individual. So just like an ACL injury, it takes about a year for the average postpartum body to fully recover, and up to 2 years to rebuild capacity. By capacity, like the ability to sustain more load and run and lift and get back to like all the things you like to do and really feel like yourself again. And unlike an ACL injury, the network of support is very patchy. Access to services really depends on different factors, your insurance, geography, workplace leave policy, and there's expectations to physically recover and resume household responsibilities, return to work while caring for a newborn.
Danielle, thank you so much. I think you set us up perfectly to dig into it. I'm already feeling fired up. So the namesake of this talk today was what nobody tells you about the postpartum experience. And I think that's exactly where we want to start our conversation. And so I'm just going to invite, maybe I'll flip it over to Jane quickly to have you start us off, but let's dig into it. What does nobody tell you about that postpartum period? What are we kind of bringing up in this conversation that you would want somebody to know going into their pregnancy and postpartum of this is what I might actually expect because I'm expecting?
Yeah, I think that description that Danielle just gave is so perfect. And I just want you to just pretend that you tore your ACL or you have a best friend who did it on the lacrosse field or whatever it was, and they were, discharged, they're on crutches, and then you gave them a puppy and the puppy is awake all night long and you have to feed the puppy, and it doesn't matter that you can barely walk because you have to keep this puppy alive. So I think what I would like more people to know about postpartum, and unfortunately this is the situation we're in right now, is that a lot of the like the resource gathering and things like that needs to come right now from the individual. So the access to care that they get, the exposure to doulas and pelvic floor therapists and perinatal mental health specialists, really the onus is on you as the individual person to go and find that care when you need it. So the networks right now are not well connected. So your OB is not going to automatically refer you to someone like Danielle, which really sucks because almost everyone should be seeing a pelvic floor PT. That should just be part of your pregnancy care. You get a referral, you go, and then you have this person who you trust who can help your physical recovery all throughout. You know, mental health support is sometimes offered through your OB's office, but again, that's very patchy and not everyone has access to that. I would say the majority of people don't even know that doulas exist. You would be shocked at the number of people who I talk to who are like, there's an overnight doula. And right now that's unfortunately kind of a luxury service because it's expensive and it's not covered by insurance. We can talk a little bit about mass health coverage, which that's actually a good stride forward. But yeah, I think right now, at least, a lot of what you have to go and do is you're trying to predict how you're going to feel in postpartum. You have no idea how you're going to feel, and you're going to try to line up a team and a bench of people that you can call in, but you have no idea how to find those people or who you actually need. So I feel like we could make those networks connect. That would be great. But right now, it's about trying to help individuals, which is it's a steep mountain to climb for all of us trying to make the perinatal journey a little easier.
Yeah, Jane, I really appreciate that. It feels very much like a now what kind of situation leaving the hospital, and how do people get supported. I actually had a doula client say to me, you know, I felt like I was discharged and there was no manual, and suddenly I'm at home with a screaming child, and I have never done this before. So there's this, I think, reliance too much on intuition will kick in, but that's just not how it happens. Danielle, do you want to add anything to this, to the let's dig into it?
Yeah, so a lot of great points were just made, and kind of to piggyback on that, one thing from my perspective and scope that I hear a lot from patients is, why didn't anyone tell me? Why didn't anyone tell me this was going to happen? I think that there is just like a lack of education of pregnancy and postpartum. And a lot of this idea, I think people have somewhat of an expectation of what might happen postpartum. You hear some stereotypes, like there might be leakage, and that historically you're told to just deal with it. So I don't think that there's, I think there's education lacking in general about all of the changes that happen to a pregnant individual and then what happens postpartum, and that there are also services that where we can address these issues. And it does fall, unfortunately, upon the individual. And in some ways, like, you know, OBs like are already, they have so many things they have to do in like a 15-minute visit. They can't prescribe you a whole rehab program on top of it. But I think that one of the issues too is just that these referrals are not being made to these different services that can help educate patients after having a baby.
Totally. The networks are loose at best, and you have to find a lot of it on your own. No, thank you both so much. Amal, I'm gonna pass it over to you for our next question.
Great, thanks, Avery. It's all hitting home, and I will just make one quick comment that at the birth that I was at in the early morning yesterday, Danielle, your comments really resonating, that this idea of just deal with it is definitely a theme. And I sort of watched a resident physician who very successfully helped deliver this new baby into the world, was doing what's pretty standard after a vaginal birth, which is assessing like whether or not there's been a tear. And she confirmed, okay, well, you've got a secondary tear, and you know that's pretty average. So average meaning it happens to a lot of people. And she, you know, proceeded to start repairing that tear. And the scene really is new mom, first baby, just gave birth in lots of pain, trying to bond with baby, and also presumably trying to listen to somebody explaining to you that you have this second-degree tear of very sensitive tissue on your body. And it's sad to me that this is sort of the way that it goes, but like that's basically all the information that was given. Like, yep, the sutures will resolve and you're good to go. So just wanted to highlight that as a like very recent relevant example of something that just occurred less than 12 hours ago. But yeah, it is the norm. What'd you say, Jane?
Probably happening literally right now to someone else.
Oh yeah, just it's so standard.
Well,
But
it goes back to the slide about the ACL, where like a tear, if it's not mobilized, is going to turn into painful dysfunctional scar tissue, which also leads to a whole host of other issues. And if you have like you get into PT really quick after an ACL injury to prevent like scar tissue buildup. And you're mobilizing that tissue really quickly. So it kind of just goes to like, we don't really think of, you know, we don't want to talk about it so much as an injury, but from a physical therapy standpoint where we work with the musculoskeletal system, there are big changes to the body that we would not ignore in any other scenario.
Yeah, I feel like it's almost like, ew, gross, a vaginal tear. Even though like 50% of the population has vaginas, it's not that big of a deal. And a lot of that population are mothers, and the risk of you getting a tear is really high. It's just sort of biology of what happens. And even like, you know, even women to women, mom to mom, there's a stigma of like talking about your tear. So I think it's just like we have to kind of break that, because it's, you know, it's a part of life and it happens to so many people, and it's not gross. It's just a body part. So
yeah, love that, Jane. And I just think we could have a whole nother webinar on what nobody told you about scar tissue, because I feel like my PT kind of told me, and I was like, what? But I appreciate, Danielle, you being able to shed light on that, because it is wild.
truly.
I do want to just add one more thing to this slide before we hit next, is that I think one thing that's just not talked about a lot with the postpartum phase is there's just so much confusion about the timeline of like when you can get back to activity, and this is an area that's really changing a lot in the world of physical therapy, like what we know and what we've researched, but it's not made its way into like the medical community at large. So there's so much confusion. And then if you're not sure, if you're afraid that like, if you've heard like, okay, I don't lift more than 10 pounds, you know, and your baby weighs 12 pounds, like you're afraid of doing anything. And you see a lot of struggle with identity in this time period. And I think that a lot of women, when they're pregnant and about to have a baby, and something really, for many people, is very exciting, like don't expect to have a little bit of an identity crisis potentially. So that's another like place where having access to professionals who are able to help with rehab and the birth process and education can be really valuable for postpartum patients.
Absolutely.
Yeah, like no one told you it's okay to want to go to Target alone without your baby and not feel guilty about it. Like you still are human outside of being a mother or a father, a parent in general. But thank you. All right. So I think, gosh, we could have whole webinars about all of these slides. So we wanted to give you all an opportunity to just kind of give us a flavor of how does your support change when you're supporting somebody in that prenatal period versus supporting somebody after having a baby. And maybe we'll start maybe with Danielle, you this time, because we started with Jay on the last slide.
Yeah, it definitely is different for me. So with pregnant patients, I'm calling them patients because I'm PT and they're my patient. So with pregnant patients, I'm not really seeing patients that often unless they're in pain, like they really need like a lot of rehab. Usually I use this time to educate on the changes that are going through their body. I'm working on expectations to kind of like revisit that last slide and help address some of the gaps in what people might expect. I'm working on keeping them strong because this is a time period where pregnant individuals actually can become quite deconditioned and are told to not do a lot of things, which our research has helped disprove. So I'm not seeing them as often, but I am doing a lot of educating. And then postpartum is really where I'm actually working a lot with my patients, and I'm trying to see them as soon as 2 weeks postpartum to help calm fears and educate again and answer questions and start to actually, implement the rehab process and the protocol. And then as the months go by, we're decreasing in visits, but I'm still available as a resource to help guide them. That's not standard for PT. And usually you're not going to see a patient until at least 6 weeks because that's when they're medically cleared. And so that's an area where I have tried to close that gap a bit and try to get the patients to come to me quicker during the pregnancy and quicker during postpartum. But unlike a doula, I am not involved in the actual birth process.
Thanks for sharing that. I want to note that I had the opportunity during pregnancy to go to like a PT class. Essentially, it was a really interesting model where I think in my area, similarly, this wonderful PT who specializes in supporting women was like, how do I get more people to like learn about my services and come to me after? And she does this really kind of cool exercise class that has gained a lot of traction and talks a lot about that idea that pregnant people are being deconditioned because they're being told not to do things while they're pregnant. And I felt so good up until my delivery because I had worked with a PT and basically she convinced me that like I shouldn't be in pain and I should feel strong, and like it was really eye-opening for me. So just wanted to give that like some more excitement because it is just so amazing, Danielle, what you and your colleagues are able to do, and just more people should know about it. So anyway.
I was going to add to Danielle, as we were talking, it made me think a lot about how the focus on a pregnant person is so, it feels very like we're thinking about both of you, person who's pregnant and baby. And then the postpartum, it often shifts to be, okay, all heads turn to the baby, every single one. And it feels like there's this opportunity that you have in the supporting in the postpartum phase where actually we're saying, well, what about your body and what about your healing and what about your sex life and what about your relationship? And there's pieces there that I think we don't have as a society, that the person who just gave birth is a whole human who still needs care for their whole selves, even though they're kind of going back and forth between pediatric visits, but not necessarily the visits for themselves. So just naming that, I feel like that's a intensive shift where once the baby is born, we see heads kind of leave from the birthing person.
Absolutely. Yeah. And I think that there is like a little bit of a stigma about feeling, or at least speaking with many of the patients I've worked with, where they feel like they can't complain or vent or be upset about any of the changes or struggles that they're having with their recovery or with their body, because there's this idea like of kind of, it was all worth it, and I can't say these things, which obviously is a huge disservice.
I was going to add to that, like the emotional, like the physical healing part, and then like everything that you guys just said about physical, same thing happens emotionally, to just dovetail what off you're saying, Danielle. So I think people are like, we talk a lot about in sort of the doula world of like, we talk about birth as almost like the wedding. There's a lot of, especially if you're someone who gets a birth doula, there's a lot of prep, especially in your later trimesters. If you have access to a good OB or a good midwife, you're seeing people almost every single week. You have a message portal where you can ask them anything you want. And then, you know, the focus is all on the birth, right? Like, you know, it's like in every TV show, and then there is no depiction of postpartum. It's just this, either it's a magical bubble, which I think we all feel like we have to feel, and if we don't feel like it's magical, then somehow we're not bonding with our child and we're already a bad mom and we're after this horrible start. And on top of that, your care has like a stiff plateau, like a steep plateau rather, where like after that 6-week OB visit, and this is not the fault of the OBs, like they just have other patients, they don't care about you anymore because they have to ship to the pregnant people, right? Like, so even if you go to them with a question, most likely they're gonna go say, talk to your PCP, or, you know, talk to whoever other specialist you might need, which is frustrating because you're like, I've built this relationship with you. And then on top of that, there's going to be, just like Avery was saying, so much attention on the baby, right? You're going to have family and friends. And in those first, you know, 1 to 4 weeks, you're going to have this village most people will have. And then that plateaus off because it's been 4 weeks or it's been 6 weeks. You're medically cleared and, you know, you should just be living in your magical bubble. But not everyone is, and it's so common to not be in a magical bubble, and you get kind of more isolated if your partner has gone back to work, or, you know, people just aren't checking in on you as much, and like Danielle said, it takes a whole year for your body to kind of heal from giving birth, and emotionally it can take, you know, 3 to 5 years to feel like you know who you are as a person again. So it's just interesting, like we kind of talk about postpartum as like, if birth is the wedding, postpartum is an actual marriage, which, you know, I think all of us are happily married, but there are parts of marriage that are really hard and no one prepares you for them and doesn't give you like a warning of like, hey, this might happen. And if it does, you know, if you're crying in the shower every day after you've had your baby, here's a list of perinatal mental health professionals who are more than happy to jump in and can probably be covered by your insurance. And it's not embarrassing. Like, we kind of need to think, we can need to think about the whole body of like physical healing, emotional healing. And I think it's even like kind of a stigma to even say emotional healing, because it's like, well, why would you have to heal from this amazing experience and you now have a child? And it doesn't mean that you don't love your kid. It doesn't mean that you made a mistake. It doesn't mean that you're not a great mom. It just means this is really hard and you need some help.
Jane, everything you said is resonating. I feel like one of my most recent births that I attended, it ended in a C-section. Basically, everything went differently from how the person planned it would go. And at every phase where it felt like her autonomy was just kind of being taken away a little bit, it was always, well, think about the baby. Your baby's almost here. And then when the baby was here, I was like, no, see, like everything's fine. Baby's happy and healthy. But there's a person sitting in this hospital bed feeling like, well, that really wasn't fine for this entire 18-hour journey for me, but I am happy that my baby's here. And so it's really conflicting. And I think it asks birthing people to give up some of themselves to become parents, which of course there's sacrifice involved, but you also are a human. You also deserve to be seen, held, and cared for, and supported in this postpartum experience and transition to parenthood.
Too, with C-sections especially, parents who go through a really long labor and then it goes through C-section, or anyone who goes through a C-section, that's a major surgery where you're actually awake. So you can hear what the surgeons are saying, you can hear what the nurses are saying, you have an anesthesiologist talking to you, but like you don't know what's going on, but you are awake, right? So that's traumatizing. There's a lot going on. You have no idea how you're going to react to that situation. And it does happen where moms are like, I'm too overwhelmed. I don't want to hold my baby right now. Can he go to my partner, or can the baby go to my partner? And people are like shocked about this, and they are like, think that they're horrible moms. And you're like, it's so common where you need an hour or 2 hours, and that's okay. But again, we don't prepare moms for things like that, because it's like, do you want to talk to them about everything that might happen in a C-section and freak them out a little? Or do you want to just say, no, it's going to be a magical experience? So it's a hard, kind of balance to strike, I think.
Yeah. I feel like another title for this could be When the Golden Hour Isn't That Golden, because I think there's a lot of getting involved in that. I'm gonna
like, there's something wrong with you if your golden hour was bad. Like, it's okay.
I know we're running out of time, Avery, but I wanted to add one nugget too, because I really feel like, yeah, that emotional piece, like just to double down on it. Like the amount of people that I've heard say, I didn't even process my birth until I was about to have my second child. Like, it's wild. And I think, Jane, to your points, like, we don't create space for that. And whatever your birth story is, it's a story that should be processed and should have space given to it. And yeah, it's wild. It's all very wild. But moving on, because we only have 13 more minutes.
Well, so much fun here. I think we've covered in a lot of ways how can this system better work together. But we'd love to hear from both of you. How do you think about partnership in the community? And I know the folks who are joining us on this call today are in various spaces in healthcare, administration, thinking about kind of how do we build more resilient systems. So we'd love to just imagine maybe how are you seeing this work today with these handoffs, referrals, transitions of care? Why is it important, and what could go differently in the future?
Yeah, I mean, one of the things that I focus on a ton as an agency is we keep a pretty curated list of resources that, is better than Google. So we either know doulas who know these people personally, or we've had families and clients use these services and know that they're really high quality. And so we create our own networks, right? So Danielle is in my network. I literally referred someone to her 2 days ago because again, I know where Danielle is. I know that Danielle has a mobile clinic. I know what this person needs. I know that they're going to be a great match. So I think a lot of what I try to do is just lower the barrier to get to those other services. So if that means a doula or myself, their specific doula or myself as the agency owner is reaching out to the therapist or reaching out to the physical therapist, making sure, do you have capacity right now to take this person on? I think they're a perfect match for kind of what you're doing. We clear that way. We send them the contact info, and then the client literally has to do nothing but send an email. They don't have to do research. They don't have to wonder. You're kind of like making sure you can just instantly make that connection. And I think the more we do it, the bigger our networks grow, and we're kind of, you're working with like-minded people that can kind of give the best service. And like, hopefully that can just continue to grow. And we are linked in with some OBs, and we are linked in with midwives. And so I think those connections are being made for sure. I just think there's a long way to go.
Yeah, it's really, with PTs, we're typically working in silos. Like, we're usually in like an outpatient practice with just PTs, and I work as a solo clinician. You're not really like with the OB and with the nurse, you're not really part of that care team in the postpartum world. So I'm not really working directly with other clinicians, but we need to be networking with them, and I need to be able to call a urogynecologist to discuss a referred patient. And so we do have to have these established relationships, but part of, you know, and it is, I think it adds to the burden of care a bit, but we do have to take it upon ourselves because we are lacking state and federal policy that just helps this whole system for postpartum care. We have to kind of make these efforts ourselves to network with the OBs and midwives and doulas. And for me, I work with a lot of runners, so I have to meet with track clubs and coaches and running shops and do all these things so that people just know we exist and that we are there to help, and that we have these services. And I think that's one area that that if we can just get, I already said this, but like if we can get the referrals quicker, it's going to help with a lot of the problems that come down the road.
Feels like a lot of resiliency. Oh, sorry. Go ahead, Jane.
No, I was gonna say, that way you can, like, part of this has to be individualized, right? Like, you have to be thoughtful about who you're referring out to. You don't want to just like throw everyone to one pelvic floor PT, because like if you have a very athletic mom who's trying to get back, like, okay, that's going to go to Danielle because she has a sports medicine background. Like, we do have to be thoughtful about that kind of stuff. So like, again, that's another layer of complexity, but like we can do it. And the referrals can be, hopefully if we can get better referrals, they can be more tailored to what the individual actually needs.
Yeah.
Sorry, I didn't mean to cut you off, Avery.
No, that's okay. That was perfect. I am watching the clock and we would love to see if people have questions. So in favor of maybe coming back to our last slide on big picture, so we'll come back to that if we have some time at the end. I would love to see if there have been any questions in the chat, folks chiming in with anything, just so we can answer a few of those, and then we'll end with some maybe big picture vision of where we could go.
Sure. We have time for maybe 2 or 3 questions. So the first one I'm seeing come through is, if you had the ear of policymakers, what's one change you'd recommend to improve postpartum outcomes across the board?
Fun.
Oh, that's a good question. Medicaid.
I would obviously want them
to say it under your breath, Jane.
Don't cut Medicaid. Sorry, go ahead, Danielle.
Yeah, I was saying I obviously would want them sent to me right away. I mean, that's my answer. Selfish. Yeah.
Like that you, like, as part of its insurance covered, as part of being a pregnant person, you automatically have a nurse or a doula or someone come to your home. They can weigh the baby, they can do that. You don't have to get in the car and go to the pediatrician's office. They can be there, they can talk to you face to face about what you actually need. And then we have to lower the cost of some of these other services for people. But I think that step of just having it be like an automatic home visit from a nurse from your OB's office, or, you know, maybe it's an actual midwife, like anything like that, I think would be like life-changing for those first couple of weeks postpartum, which sometimes are the hardest.
I can follow that, unless you are like on the edge of your seat, Danielle.
Oh no.
Jane's answer would have been like my answer, so I think I'm between 2. Paid family leave is,
Oh yeah.
it is embarrassing that when people say, oh, I got 12 weeks, that the response is, oh my God, that is so amazing. How lucky are you? It baffles me that we think that 12 weeks of 67%, if you live in a state like Massachusetts, is enough to be able to do all of the things that we've talked about on this call today. And so that's my response. Like, we have got to get a federal paid leave policy that isn't FMLA, that doesn't pay you. And also, by the way, you have to be at your job for, I think it's 26 consecutive weeks to even be be eligible for protected unpaid leave. So that's a whole thing. But we need longer paid leave. So not just 12 weeks, we need at least 6 months. That would be minimum of paid leave for both caregivers, not just the primary.
Oh, partners.
Yes, because being a person who has just given birth and not having your partner is like quite possibly just, I don't even have words. So that's it. I'm going to stop talking. That paid leave, good paid leave.
We have a lot to say to the policymakers.
No, we should have all of that.
I'm sure. And then, oh, I'm sorry, go ahead.
I was going to say paid leave, universal home visiting for all, expanded mental health supports in the postpartum phase. Yeah. Yep. So those are our wish lists if there's a policymaker on the call today.
And then the last one for tonight is kind of looking forward. So are there any emerging models of postpartum care that are giving you hope for the future?
So I can talk a little bit about what Mass Health has done. I don't think it's a perfect program, but I think it's pretty great. We have some doulas on the team who are Mass Health certified doulas. It's a complicated process for the client and the doula, but I still think it's happening and people are getting connected. And you can kind of, essentially, it's a insurance that will cover a doula. Either that's for kind of prenatal support, birth support, and then they do sometimes cover postpartum support as well. The people are kind of matched with the doula. We're doing a good job with having enough Spanish speaking doulas so that people actually have support in their native language. So I think there's been some pretty major strides to the Mass Health program, and I really hope that they just continue to expand that. I think we need to tweak it a little bit because there are some policies that don't really align with the way that care is provided, but just the fact that it even exists, I think, is such an amazing first step. And again, that's going to populations that need it the most, that, you know, having a doula who speaks your own language, who then can translate without having a random translator in the room with you, is huge. So I think that's a big shift that only happened in the last like 2 years, I think. So that's, you know, positivity. I think Mass Health has done a really cool thing, and I think they can continue to refine it and make it even better.
Yeah, I will echo that, Jane. I think there are a lot of states that are trying this, especially as it relates to doulas, which is a little bit of a different type of provider because it's not like a licensed profession. And so a lot of state Medicaid systems don't really know how to manage that. And so it is great. We're doing the same thing in New York State. I think we were like the first state, but we are still like pretty behind on our implementation. And similarly, it's really hard for doulas to get into it and then get paid. So we have a lot of work to do, but it is great that that is starting. I'm gonna throw in a kind of an interesting one. And I know the question was about models of care. I'm just gonna be honest, I don't really know about any models of care. So I think we're more sprinkling in some interesting policy wins. But one that I think is interesting that we may not think about in the postpartum period because it typically comes later, but given that we don't have paid family leave, I think this is really important to think about childcare. We're not at the point of thinking about really high quality early childhood education, which is what I would like to be talking about. Really just we have a shortage of access, and it's really unaffordable for caregivers and parents to get their children cared for just minimum during work hours so that they can go and have a job. But New Mexico has recently announced a universal child care program, which I think the entire country is watching to be like, how's this going to go? So I would keep your eyes on that because that's really, it's really exciting to see a state like try to do this for parents. It's probably one of the top needs across our country, and I think most people can agree that we would like to have childcare for our children. So that I think is a cool policy win, and hopefully it works.
And just to piggyback off that, just to like show how it ties in, is like the number one reason my the cancellation rate would be so high when I was working in the clinic is because moms couldn't get to the clinic because they didn't have the childcare. Which is why I work mobily now and go to their homes to help, again, with address that barrier, but it does affect access to care.
Absolutely.
I think, and this kind of ties it back into that question of like models of care, like when we center the person and think about like what are the reasons why this person might not be able to access? Is it geography? Is it transportation access? Is it like payment ability? That's how we can shape more robust policies, more sustainable policies to support people who we are. So I think that was a really great question. Thank you.
Yeah, and on a positive note.
Absolutely. Thank you very much, everyone. We're right at 7 o'clock. That was an incredible talk and an extremely important one. And I will, like I said, I will be sending out this recording to everyone tomorrow morning once it becomes available. But if you have any further questions or you're thinking on this information and think of something that you wish you asked, the information, like I said, will go out with their contact information as well, so you can reach out and address anything. But again, thank you so much, everyone, for speaking with us this evening. This is, again, a really important conversation that needs to continue. So thank you for amplifying that.
Thank you, everyone. Thanks for attending.
Thanks so much.
Yeah, thank you for letting us talk about this. I'm like fired up. So talk to
Me too.
Great, let's keep going.
Keep talking.
Absolutely, of course. Thank you so much, everyone. Have a great night.
Thank
Have a
you.
good one.